this next section of this programme, it absolutely gives me great honour to chair. There's many faces in the room that will remember Nicky Ward-Abel, and for those of you who don't, I just want to give a little bit of background. Nicky Ward-Abel was a lecturer practitioner of Birmingham University, and she was a very precious commodity. And her overriding passion, apart from dancing on tables at the end of conferences, was education for MS nurses. And she was very much the driving force behind this conference. It used to annoy her intensely, the bridge and the gap between the education that our medical colleagues got and the education that nurses got sometimes. And she wanted that bridge, that gap bridged. And so she got in touch with David and the At The Limits team, and very much this was her baby. Unfortunately, she never saw the fruition of her dreams, but by God is her legacy living on. And we just felt it really important that she was honoured in this programme. So again, I'm so proud that this next section, it's the nurses that are doing the talks, because, you know, I can hear her going, go on, girls. So no pressure. And what was really nice is that we've got 2 talks. So it is really important, I'm going to say this, you know, shout about what you do, be proud of what you do, and you'll get the chance to be up here and talk. So let us know. So first off, to open up is Miranda. I have to put my specs on, Miranda, so I do apologise. It's old age setting in. So Miranda is going to talk to us about the value of nurse prescribing in the management of people with progressive and advanced MS. Miranda has been an MS nurse for a little while, so and does have a special interest in people with complex and advanced MS and pain and spasticity management. So over to you, Miranda.
And I'm very honoured to do this. How do I change the slides? The next button. That's obvious. So can I get a show of hands so I understand who I'm talking to? How many are nurse prescribers in the room at the moment? So I'm going to be completely open. Thank you for that. A lot of you are going to have a lot more experience than me. But I'm a new prescriber, and this is very much a personal reflection. It's not part of the learning set about how to become a nurse prescriber. But it's also to encourage those of you who are not yet prescribing and who are maybe considering it to go for it. And one of the reasons I thought I can do this is because I am actually probably the most unlikely person who would be standing up doing this talk. I resisted nurse prescribing for over a decade. I was absolutely terrified of it. I am very, very wary about drugs. I'm a massive advocate for lifestyle, holistic therapies, all those kinds of things. I'm very afraid of drugs myself, barely ever take a paracetamol. I'm very much afraid of causing harm to any of my patients by, having an adverse drug event. I don't want the accountability, and I don't think we get paid enough. So those are my disclosures. So that's where I started, and that's why I can kind of share with you how I turned around, how I think about this. Anybody who is wary of prescribing and wary of drugs is thinking in the right way, because drugs kill thousands and thousands of people around the world every year. This came out in 2019. It was a fantastic study within the NHS of how many adverse drug events there are and what kind of harm results from them. And there are 1,708 approximately deaths every year within the NHS from definitely avoidable adverse drug events. So I want to tackle that head on first of all, because that was my biggest fear and still is, and we should be afraid of that. So I found this fantastic graphic, which is copyright to, that's just shared down there. And that just breaks this down a little bit. So basically, on the right-hand side of that tablet, where you can see the number of the number of adverse drug events is actually 237.4 million. They don't all result in serious harm. This side is what stage of medication use they occurred at, and this side is what care setting they occurred in. So in actual fact, when you look at all these errors, this is prescribing. This little donut here is the actual prescribing. So only 21.3% occurred within prescribing, and about half resulted in minor harm. Slightly over half resulted in moderate harm, and only a very small percentage in severe harm. Most of the adverse drug events took place in administration and disproportionately in care homes. And I did some shifts in a care home a few years ago when the firefighters were on strike, and I can see the strain the nurses are under in care homes to just do a continuous drug round that lasts for about 12 hours. I can understand why. The ratio means that so there are more patients, there's more prescribing going on in primary care, there are actually, the ratio of adverse drug events is higher in secondary care, but there are far more patients in primary care. And the World Health Organization has a goal to reduce this by this year by 50%. I don't know if that actually happened, but it's a good goal to just continue with. So actually, the drugs that cause the most adverse drug events are not generally the drugs that we're very much prescribing in neurology. It's more about gastrointestinal bleeds, these drugs here, and the anti-inflammatories, anticoagulants, and antiplatelets actually caused over a third of the admissions due to avoidable adverse drug events. So that's, somewhat reassuring, the fact that it's not generally the type of drugs we're using. Now, there was a government paper came and had a look at how do we start reducing, how do we start reducing these events? And they came up with a lot of suggestions, some of which we have less control over as prescribing nurses, things like changing the packaging, having drugs that don't have very, very similar names to each other. We're less likely to be able to influence those things. But 4 of the suggestions are things that, can affect our practice. So the first one was using electronic prescribing systems. So in the community where I work, we all use electronic prescribing. I'm not sure about what type of prescribing or electronic prescribing is going on in the hospitals, but if you're in a situation where you're prescribing using paper pads, I would be pushing for your organisation to roll out electronic prescribing. Electronic prescribing doesn't stop you prescribing the wrong drug or not noticing what conditions your patient has, that you should have avoided prescribing that drug for, but it does highlight, it brings up all the interactions with the other drugs that the patient is on. It also gives warnings about, breastfeeding or whatever. There's certain prompts, and it stops you making spelling mistakes and, writing illegibly and things like that. And it goes straight to the pharmacist. So the pharmacist already has it. It's been shown to make things safer. So one of their suggestions was improving the information available to patients to promote joint decision making. And that's something I'm going to be exploring further, because I think that's where, as nurses, this is where we're perfectly placed to do far more education, far more joint work, and just make the whole prescribing scenario far more interactive. Embedding education and CPD, we need to really fight for our rights to stay up to date. It's all very well going on the prescribing course, but if we don't get designated time where we can get our updates and attend forums for prescribers and things like that, it'd be very easy to fall behind. And that includes in our specialist areas, so attending things like this so that we're up to date with the drugs. And reducing inappropriate polypharmacy. So in progressive and advanced MS, a lot of our patients are older, they may have a lot of comorbidities, and they could have been put on loads of different drugs over the years by loads of different people. So in actual fact, deprescribing is as important as prescribing. It is as as clinically important and as important to our patients' safety. Also, remember that non-medical prescribing is only for prescribing within the scope of our professional expertise and competence, so i.e. in our specialist area. And you become proficient and competent in certain areas, and there are areas where I feel that it's maybe appropriate for me to get competent in those areas, but I'm not competent there yet. So I have some patients who are on opiates and who have palliative care involved, and I'm not touching their opiates. I will get a palliative nurse involved, or some who haven't had palliative care involved, but somehow they've ended up on a lot of opiates. When I'm getting involved with their medications, I get the palliative care team involved, and I don't want to take that one on myself. So how do we keep ourselves safe? Now, I don't know why, and it might be because this only came out recently in April 2021, but when I did my prescribing course, we weren't told about these guidelines, but this is basically the General Medical Council's guidelines for good practice in prescribing and managing medicines and devices. And it's not flowery. It doesn't go on and on about, all kinds of beautiful relationships that you set up with your patient and everything. It's just a really clear set of guidelines. If you prescribe like this, you're probably not going to make a mistake that will cause harm to your patients. And they have various topics, which I won't go through all of them now, but you can see these are the main kind of headings. It doesn't take long to read, and it wouldn't take long to print it out and, have it with you alongside the very specific nuts and bolts of prescribing. So, thinking about people with progressive and advanced MS, they tend to have, so I guess what I'm thinking about now is what changed my mind. My caseload is very much these people with progressive and advanced MS. Two huge symptoms that almost all of them will have at some point: pain and spasticity. Now, medications for pain and spasticity, they don't come in a kind of pack, a format. There you go. You take 22 milligrams and then 44 milligrams, and that's you done. Basically, one size does not fit all. So, very much not. So these drugs absolutely have to be titrated. They are not effective if they're never titrated up to a therapeutic dose. It really doesn't matter if someone's taking 20 milligrams 3 times a day if what they needed was 25 milligrams 3 times a day or 30 milligrams 3 times a day. The number of times you will hear your patients say, "Oh yeah, I've had that drug, it didn't do anything for me. Oh, I had that drug, I can't take it. That completely knocked me out." But what dose were they started on? And was it ever increased? And did it start slowly enough? So we quite often need to kind of take things back to basics because we don't have a huge formulary. When we're trying to manage pain and spasticity, there's a really limited formulary. And if people are kind of just writing off one drug after the other because it was never actually effectively titrated for them individually, then they've ruled out pretty much, they can very quickly rule out all the treatments that are available to them. So drugs are also not effective if they cause a worse problem than the one that they came to solve. So titration is really important. 3:40, does that mean I've got 3 minutes 40 left? Because I'm going to speed up, right? Okay, so drug titration is really important. This is a great paper. It's called The Art and Science of Drug Titration, and I recommend having a read of it. And the key really is that it optimizes pharmacotherapeutic outcomes and improves drug safety. So as nurses, if we do this properly, we can make drugs both more safe and more effective for our patients. You may need to titrate your drugs up, you may need to titrate your drugs down, and you may need to titrate them across. Because quite often, actually, the first medication you tried didn't work. And so then you need to try the next one. But how do you do that? And there are some really nice guidelines that you can find out there. One of the ones that I use a lot is this. which I basically found by searching about online, which is a really useful, it contains a useful guide for switching from gabapentin to pregabalin, because that's a very common one. Can't tolerate gabapentin. However, lots of people who can't tolerate gabapentin can actually tolerate pregabalin. So drug titration is a form of personalised medicine. That's all I'm going to say there. There has been research on how effective nurses are in prescribing. In this piece of research, which was about patients' views, patients believe that nurse prescribing improved access to and efficiency of services. Basically, if someone's prescribed a drug by a neurologist and they're going to be followed up after a year, it's not that useful. If somebody's prescribed a drug by a GP and they're never going to be followed up, or a pharmacist is going to give them a call in 6 months to try and get them off some medications, it's not that useful. But if you can prescribe a drug after really carefully consulting with the patient, thinking about all the options, doing all your safety checks, and then you phone them every week until things are stable, even if that means going on 3 months with a 5-minute phone conversation every week. Okay, that one didn't work. Let's try this. Let's take it up a little bit. Let's take it down a little bit. Let's get the physio involved. You're more likely to come to a safe and effective outcome. This was just kind of what I was talking about, how you basically have different areas where you feel like a novice and different areas where you feel like an expert. But one of the things I'd kind of like to draw your attention to is also pretty obvious, is that these are kind of longer. So once you get to the point where you're prescribing the drugs that you use a lot for your patients, it's just so much nicer to do that more quickly. Now, the only times for me that drugs are really urgent is when my patients have UTIs or are having a relapse. And then it feels like a real lifesaver to be able to just do the prescription and say, right, it's at the pharmacy. As soon as the pharmacy can produce that medication, you can take it. And that is incredibly useful. Right, I'm going to check I haven't missed out anything. Anticholinergic burden, that's really important. That slide's gone strange, but that was really just sharing the kind of things that I ended up prescribing most frequently in my first year of prescribing. And, sorry, it's not any kind of advice, it's just this was my experience. This is what I ended up prescribing a lot, and I'm sorry it's gone transparent and I don't know why. Okay, and the last slide. So in summary, stay wary. We can make medication use safer, more timely and more effective for our patients, and thereby improve their quality of life and enhance our job satisfaction, but we still don't get paid enough.